All right, hey everyone, and welcome to this high yield explainer. I am absolutely pumped to guide you through this material today. We're taking a really comprehensive patient journey approach to the absolute most critical prostate cancer data you need to know, not just for your board exams, but for your day-to-day clinic as radiation oncology residents. We're going to break down some of the most complex trials and strict dosimetric numbers into really clear, structured takeaways. So let's get you ready to master the evidence and actually apply it to your patient care. So here is our roadmap for today. We're covering localized prostate cancer trials, post-operative adjuvant versus salvage timing, hormonal therapy and sequencing, nodal and metastatic disease, and we'll wrap up with brachytherapy and dose constraints. Starting right off with Section 1, localized prostate cancer trials and the evolution of fractionation. We're kicking off our journey with localized disease, and specifically, we're focusing heavily on how we've pushed the limits of daily radiation dosing over the years through hypofractionation. This is a perfect contrast and compare lesson. Think about the Hypro trial. They pushed the dose all the way to 3.4 gray per fraction, and well, it resulted in a concerning 19% late grade 2 genitourinary toxicity. Plus, it just wasn't superior. But on the flip side, you have to chip in RTOGO 415 trials. They found the absolute practice-changing sweet spot at 3.0 and 2.5 gray per fraction. Those regimens proved safe, completely non-inferior to conventional fractionation, and they literally changed our daily practice overnight. Now, you might be wondering what happens when we push the envelope even further down to just 5 fractions. Enter the PACE-B trial. The 5-year biochemical control here is just outstanding. We're talking 95.8% for SBRT versus 94.6% for standard IMRT. So, non-inferiority? Definitely met. But the crucial point you have to take away from PACE-B is that while 5-fraction SBRT is incredibly convenient for our patients and highly effective, you absolutely must counsel them on a slight bump in cumulative late GU toxicity. It's essentially a trade-off between immense convenience and a slightly steeper toxicity profile.
Moving right along to Section 2, postoperative adjuvant versus salvage, where timing is literally everything.
We have to talk about the age-old debate in radiation oncology, immediate postoperative treatment versus wait and watch. Well, the bottom line across 3 major trials, Radicals RT, Gets You AFU17, and RAVES, was pulled together beautifully in the artistic meta-analysis. And the answer is ruthless and clear. When you look at the 5-year event-free survival, it's 89% for adjuvant versus 88% for early salvage, meaning there is absolutely no oncologic benefit to routine adjuvant radiation. And to make matters worse, adjuvant therapy carries a significantly higher risk of GU toxicity. So this data firmly establishes early salvage radiotherapy as the standard of care. But there is a catch. The penalty for delaying that salvage radiotherapy is severe. Data from Tendecker colleagues clearly shows that outcomes are heavily dictated by the patient's PSA right before you start salvage RT. Once that pre-salvage PSA crosses the 0.5 threshold, the 5-year freedom from biochemical failure just completely plummets from the high 70s down to the 50s and even below. So the lesson here is simple. You have to catch them early. So, once we decide to salvage, do we add hormones? The answer actually depends entirely on the clinical picture. RTOG 9601 showed a massive overall survival benefit when adding 24 months of ADT, but that was primarily seen in patients with a higher PSA, specifically over 1.5. Conversely, GETU-GAU-FU16 showed that a short, 6-month course improves progression-free and metastasis-free survival, which is absolutely perfect for your early salvage patients with a low PSA. So your key clinical takeaway? Tailor the hormone duration strictly to the patient's PSA and risk factors. You're always trying to balance those great survival benefits against some pretty significant endocrine toxicities.
Let's pivot to Section 3, hormonal therapy and sequencing, and managing that axis.
Since we just brought up androgen deprivation therapy, let's talk about the actual mechanics of hormonal therapy, and specifically how these drugs interact with our radiation. Before we even get to sequencing, never ever forget this physiological concept for your boards, the testosterone flare. When you give an LHRH agonist, you cause an initial surge in luteinizing hormone. That spikes the testosterone before it finally drops. Because of this, you absolutely must use an anti-androgen, like bicalutamide, for a couple of weeks to block this flare. This is a big deal, especially if the patient has painful bone metastases or is at any risk for spinal cord compression.
It is incredibly crucial to distinguish your drug classes for the clinic. LHRH agonists, they cause a flare, and they work pretty slowly. Antagonists, on the other hand, do not cause a flare, and they suppress testosterone very rapidly. If you understand these distinctions, you can seamlessly justify to your attending exactly why you might pick a fast-acting antagonist, like digarelix, for a patient sitting right in front of you with high-risk, highly symptomatic disease.
Now, how exactly do we sequence those hormones with our radiation? Well, the Sandstorm pooled analysis gave us the definitive answer. The interaction between your radiation field size and your hormone sequence absolutely matters. If you're treating the prostate alone, lock in the concurrent to adjuvant approach. It clearly improves metastasis-free survival. But if you're doing whole pelvic RT, the sequencing is a lot more flexible. And you should actively avoid unnecessary prolonged adjuvant ADT because that can actually be detrimental. All right, Section 4, Nodal and Metastatic Disease, Pushing the Boundaries. Let's escalate our focus to patients with more advanced disease, examining exactly when to treat the pelvic lymph nodes. Enter the landmark RTOG 0534 SP or PORT trial for salvage patients. There is an incredible stair-step improvement here in 5-year freedom from progression. Just doing the prostate bed alone gets you 70.9%. Add short-term ADT, you jump up to 81.3%. Add pelvic nodal irradiation on top of the ADT, you reach a massive 87.4%. This brilliantly proves that for high-risk salvage patients, specifically those with a rising PSA over 0.35, adding pelvic nodal irradiation and short-term ADT significantly improves their outcomes. Shifting to de novo metastatic disease, Stampede Arm H is a trial you are literally going to quote every single day. They asked a massive question: should we radiate the primary prostate tumor if the cancer has already spread? The answer is a resounding yes, but only for low-volume disease, where it dramatically improves overall survival with a hazard ratio of 0.68. For high-volume disease, there's just no survival benefit at all. So the crucial takeaway from Stampede is that treating the primary tumor absolutely saves lives, but only if the patient has a low metastatic burden. So what about targeting the metastases themselves? Well, the OREO and STOP trials investigated metastasis-directed therapy, or MDT, for oligometastatic disease, which means 1 to 3 spots. OREO showed that SAB reduced 6-month progression from a massive 61% down to just 19%. Both of these trials confirm that targeting those few distinct metastases effectively delays disease progression and, importantly, buys your patient really valuable time off of systemic ADT therapies. Okay, the final stretch. Section 5, brachytherapy and dose constraints, these are the numbers you absolutely need. Let's switch gears to the technical side and cement the specific dosimetric constraints you just have to commit to memory. When evaluating a standard fractionated prostate plan, anchor your mind to the strict V65 limits. Both the bladder and the rectum must have their V65 kept safely under 15%. Respecting these organ at-risk constraints is totally non-negotiable if you want to prevent severe late urinary and bowel toxicities in your patients. But when you shift your clinic to moderate hypofractionation, like what we discussed earlier with the CHIIP trial delivering 60 gray, your conventional constraints kind of go out the window. You need to lean heavily on the Wilkins constraints, pay particular attention to the rectum here, ensure your rectal V40 is kept safely under 38%. Now for low-dose rate brachytherapy. For permanent seed implants, the whole game is about coverage versus hotspots. Focus on keeping your rectal V100 under 1 cc to protect the bowel wall. At the exact same time, you've got to ensure your prostate D90 is piping hot at over 100% of the prescription dose. That's how you guarantee you are actually curing the cancer. To make this completely foolproof for your boards, burn the numbers 95, 65, and 30 right into your brain for your pre-implant planning goals. That represents your target volume receiving 100%, 150%, and 200% of the dose. Also, make sure you note the strict urethra limits here to avoid any severe strictures. These constraints are classic high-yield board fodder that I promise you will be tested on repeatedly. We have covered a ton of ground today, but I want to leave you with a really provocative thought. Everything we know right now from trials like OREO and Stampede is based on conventional imaging. But as highly sensitive PSMA PET imaging detects micrometastases earlier than ever before, how is that going to redefine the very concept of oligometastatic or low-volume disease? It's a fascinating question, and honestly, it's one that your generation of radiation oncologists will have to answer. Thank you so much for joining me on this explainer. Keep studying hard, and I'll catch you next time.